So we're going to go ahead and get started here on time. First and foremost, I want to welcome everybody to another installment of our webinars. Today's discussion is going to revolve around the importance of regular well women care. And we have the honor of speaking with Dr. Allison Pisciuco. So welcome. Thanks for joining us.
Thank you so much for having me.
Of course. So before we get started, I just want to go over a couple housekeeping things. First, this is recorded just so everybody knows. If you miss anything, don't feel like you have to jot notes down super fast. It'll be sent out to you in a follow-up email so you can go back and rewatch it. Or for those who didn't make it today, they'll be able to see it. As well as if questions or comments arise during today's discussion, there is a chat function on here. So when those comments or questions come up, drop them in there and we'll address them all at the end during a Q&A. Okay, so we're going to go ahead and get going. I just want to start in a very general question. Can you explain what an OBGYN is? And then on a personal level, how did you get into this field?
Sure, yeah. So an OBGYN is shorthand for obstetrician gynecologist, and we're the medical providers who specialize in women's healthcare, so across the spectrum of a woman's life. Those two components, obstetrics focusing on pregnancies and delivery, and gynecology focusing on a quite wide spectrum related to any conditions that might affect the female reproductive system, all the way from prevention, monitoring chronic conditions, through surgical management of certain conditions that may arise.
And how did you get into that field?
I got into that field after enjoying it, certainly throughout medical school when we're doing our rotations in the different core specialties. And the main components that I think stand out, probably for a lot of OBGYNs actually, is that it's a specialty that allows you to participate in a woman's, health throughout the whole spectrum of their life, from teenage years all the way up into the maybe 70s or something like that, later age. And you get to be a part of some very special moments, obviously, in the obstetrics world. And then it's also a nice mix for the provider as well, going between office work, labor and delivery, which is unique, and the operating room for surgery. So it allows us to kind of stay on our toes and be working in a couple of different fields, which is pretty exciting.
Right, and what a special experience to be a part of. That's amazing.
For sure, yep.
So you mentioned that you get to work with women at different stages and different ages. So when should someone start going regularly to an OBGYN?
It's a little bit of an individual situation, but on the whole, a good kind of guide would be probably in mid-teens for a young girl to start coming to the gynecologist office. And, that doesn't mean that everything is starting right off the bat. In fact, a lot of early appointments are really just a discussion between the provider and the patient, so that those young girls who are likely to be quite nervous to be coming to the gynecologist office, which is incredibly normal to feel that way, so that they kind of understand and can learn what to expect when they come, have a little bit of a discussion of what gynecologic care really is, so that they understand what we can be able to provide assistance with, and just to honestly allow them to feel a little bit more comfortable with the process, understanding that some of the things, if needed, can be completely confidential, because gynecology obviously does delve into worlds of, in young girls, potentially one of the things we want to be talking about is sexual debut, concerns for any sexually transmitted infections, contraception, whatever else. But it does usually start out as a conversation. It doesn't mean they're going to have to get a pelvic exam right that first day. In fact, that usually isn't necessary unless certain conditions exist. So mid-teens is pretty much average. Certainly if any younger adolescents or even pediatric patients, there are certain conditions that might necessitate visits at younger ages, but those are for unique situations more commonly.
Got it. So when you start going to your annual visits, whether it be a teen or whether it's, later on, what does that annual visit entail?
Sure, yeah. So again, a little bit different focus for different age groups, depending upon what we're going to be discussing and screening for. But the overall process involves a history, so where we're going to sit and chat with the patient to learn about any other chronic medical conditions they might have, past surgeries they've had, any family history of various things, especially cancers that we want to know about. And then in the gynecologic realm, just asking them about their periods, what they've been like over their lifetime, if they're changing at all, their history with screening for cervical cancer, any known problems they have, or pelvic pain, to go through all of that. And then a physical exam is the kind of secondary component of that annual visit, where we do a full body physical exam, obviously focusing in on gynecologic areas. So breast exams are usually a component of it, as well as pelvic exams, and potentially Pap smears as necessary, depending upon kind of what's going on with the age group and other comorbidities.
Got it. So then as women get into those older stages of their lives, how does that exam shift? It's like you said, it's not always going to be the same thing. So at what stage in their life does it start to shift?
Well, so the starting of the pelvic exams would be, in the depending upon someone's history, late teens, early 20s. Pap smear screening is recommended to start at age 21. So that would be something we would start around that time. And then what I mean by, every exam could be a little different is if patients don't have true pelvic complaints or concerns, it doesn't mean that every time you need the typical speculum exam or bimanual exam that we do when looking for pelvic complaints or issues. So that's something that can be discussed at each visit, depending upon kind of what's going on with the patient.
Got it. Do you find that women more often visit their OBGYN versus their primary care doctor?
I think a good number of women, a little bit over, 50% or so, are probably seeing mostly their gynecologist for their annual visits and not necessarily following up with those primary care doctors. And, that's perfectly fine, certainly for a healthy person who doesn't have other comorbidities that need to be followed. We're able to, in those annual visits, screen for lots of conditions at baseline for things that might, eventually need to be followed up with a primary care doctor or even other specialists, depending upon what shows up. But at a baseline, it is okay to come in and see us, for things as routine as blood pressure screening, diabetes screening, a myriad of other things that we discuss at the annual visits. But yes, I do feel like women, try to, I guess, get everything done at once, and we are able to do a fair bit of that, though unfortunately not all of it. There are some things that aren't quite for our specialty to be managing, so if those are identified, then oftentimes they do get referred out to primary care or other specialists as needed.
That makes sense. Women were two birds, one stone kind of people, so I can see how that happens. Do you recommend, though, that people do go to their primary care provider annually as well as their OBGYN?
For sure, yeah. I mean, like we talked about at the beginning, describing what OBGYN is, what we're all trained in is specifically women's healthcare. And so obviously their whole health is going to touch on that. But we're not the original source or probably the best people to be providing long-term management of anything. So definitely recommend people are seeing their primary care providers as well as their gynecologist annually.
Perfect. Yeah. But beside annual appointments, what kind of things prompt a woman to go in for a visit or to schedule a visit outside of their typical annual appointment?
So any number of things probably can come up. One of the main things I think women notice certainly is going to be related to changes in their periods. So whether the frequency is changing, the quantity of bleeding is changing, if there's related discomforts that are new and different, period changes are definitely going to be a big thing that send patients in and should be seen for. Additionally, just new onset pelvic pain symptoms, vaginal discharge issues, pain during intercourse, any known history of endometriosis or ovarian cysts or PCOS that needs to be followed. Fertility is another big thing that patients obviously want to be seen for, to make sure that they're on the right track in trying to manage that going forward as well. And then a little later in life, menopause symptoms are going to be a big factor that brings women into the office to understand what is normal and what's not, as well as to discuss management options to try to make quality of life, usually in that situation, a bit better.
Absolutely, that makes sense. So when those situations arise, what types of screenings can you actually do in an office when they would come to visit you?
Sure. So pelvic ultrasound is a big component of our kind of screening and evaluation. One of the main tools that we use to evaluate for any sort of structural problems going on with the female reproductive system, as well as some bleeding problems. Other things that we do in the office, with all those annual visits, are certainly the Pap screenings each year. If those are ever abnormal, we can do in-office colposcopy, which is the step that follows Pap screening to evaluate for cervical dysplasia and cervical anomalies. Similarly, endometrial biopsies are an in-office procedure. We can do some office hysteroscopies to evaluate the uterine cavity as needed. And then other screening things related to, when we talked about taking that family history and the appointment to understand if there's any family history of things we can do and discuss genetic screening for cancer syndromes. And then the other main screening things that come up in gynecology related to breast health and bone health are not things that actually happen in the office. The mammograms, the bone density scans happen out of office, but certainly referred from in office.
Okay, that makes sense. So I have a couple questions from people who have been sent in. So I know we have some students on here today.
Okay.
Watching. So do you have any advice for someone who thinks that they want to specialize in obstetrics? I'm sorry.
Yeah, just try to get as much experience as you can. I know the students have been in a little bit of a rough boat these past couple of months, but they've all been awesome, dealing with the predicament they're in. So when able to, just getting that experience, actually seeing what it's like on a day-to-day basis, trying to come to our office for rotations, the other providers that work at HSC, so that you can see what really day-to-day office life is like, because that's quite different than when you're a student and a resident and you're in the hospital every day, to understand what it's like. But if you like anything, definitely go after it, try to get your hands wet, and see how you continue to like it as you experience it a bit more.
That's great advice. I appreciate that.
Mm-hmm.
If we could circle back to, those initial teen years when people start to come in for, maybe that first visit or maybe a visit with their parent where they want to discuss things. A couple questions. What would you tell a parent that maybe doesn't want to or is pretty hesitant about immunization for their child for the HPV vaccine?
I would just explain that, the real premise behind it is that it's able to prevent those HPV infections with those high-risk HPV strains that are going to cause cancer. It's honestly, from a scientific standpoint, a wonderful thing that was created. The first vaccine that technically is preventing cancer by preventing those HPV strains and the impacts they can have down the road. If the concerns are based on concerns about vaccination versus historically there was some concern about recommending an HPV vaccine for a population of younger girls and boys who the implication of it being related to transmission by sexual intercourse, I don't think that that's something that parents need to be overly concerned about. They can discuss it at a time when they feel is appropriate. It doesn't need to be discussed in the moment. There's lots of children getting other vaccines, certainly for measles or whatever else, that the children don't understand how the transmission exists, but the outcomes and the benefits of the vaccine are incredibly impressive, and as such is definitely something that we recommend. And just a reminder that, if a patient doesn't get it when they're younger, it's still something you can continue to get as you age if you've never had it when you were younger. So certainly something to continue to bring up with your physician, even if you're showing up for your gynecology visit at 22 years old or whatever else.
That's good to know. I had no idea. So for, again, focusing on those teen years, anatomy, especially female anatomy, is kind of glazed over in a lot of public school education. So if a young girl and their parent want to come in and get a little bit of a lesson on that, is that something that could be done in one of those first meetings with you as a doctor?
Yeah, for sure. And that's what, those early appointments for those early teens, when I say it's more of a discussion, that's what can kind of be discussed, trying to figure out what the teenager's understanding of her own body is and what her understanding of her cycles are. And so explaining those a little bit, because oftentimes, yes, with that explanation, some things make a little bit more sense as time goes on and they might change or anything else.
Okay, perfect. Another question that I have on here, do you encourage younger females to get on birth control mid to late teens, or do you see there being long-term ramifications because of that? Or is it case to case?
It's a little bit case to case, and I don't think, we have all of the information just yet. I think the most important thing to remember is if a person and a young woman is not ready to have a child yet, then she needs to do the most she can to try to prevent that. There hasn't been any information to make us think that the implications or the outcomes of long-term use of contraception are going to be negative. So more important would be preventing that pregnancy if that's not something that young girl wants.
Understood. Yeah. And, nowadays I don't even know how many different types of birth control. So how do you go about deciding what's best for each individual female?
Yeah, it's a real discussion between the physician and the patient to see what might work best for them. Everyone is a little bit different. Birth control pills are quite well known, but birth control pills require you to take a pill at the same time every day, which some people, teenager or 45-year-old woman, are better at than others. So making sure that the patient understands that part and is a little bit honest with themselves about their ability to commit to that. And then also just understanding where they're at in their life, whether or not they just want a little bit of time before pregnancy, maybe they want a really extended amount of time, to try to determine what might be best. And then there's some things where some medical conditions outside might have an impact on what's recommended as well.
Got it. So, we've been talking about teens heavily, but let's go to kind of the other spectrum. What are the upper age limits for pregnancy? When does age become a factor for women when they're trying to start that family?
Sure. So technically, advanced maternal age as a diagnosis is considered at age 35 and older. So some implications start at 35 and then even more so over the age of 40. Those are kind of delineating numbers that we use to guide how we might manage things a little bit differently in a pregnancy.
Okay, makes sense. I have another question. Somebody sent it in. You had mentioned bone density scans. At what age is that needed for a baseline? And are there data points that determine this age?
Yeah, so it does shift around a little bit based on a patient's kind of personal history. So those are things that don't start until more postmenopausal age group, but it is a little bit specific based on family history as well as individual factors.
Okay, that makes sense. Another question that was sent privately, it says, what are your thoughts on preventative visits for a person who has had complete hysterectomy? And when should they have some kind of exam to make sure that nothing is happening? And on the same thought, what is the likelihood of bladder problems when a hysterectomy is done?
Okay, so in terms of the recommendation for preventative visits continuing post-hysterectomy, it's still something that should be done more or less annually. Depending upon history before, there might still need to be certain screening if there is still a cervix remaining, or even if there were abnormal pap smears prior to a hysterectomy. Even if that cervix is gone, we still need to evaluate the vagina around the area where the cervix is. So that's something that should continue, so you're staying on top of that. Also, because you can develop other symptoms, you can develop, pain with intercourse. You might still develop menopause symptoms depending when you had the hysterectomy and what time, whether or not you were menopausal or not at that time, and whether or not you still retained your ovaries. You can still have issues with vaginal discharge, and obviously then the other annual screening things related to breast health, bone health, and all the other screening we do for overall wellness.
Okay,
and then I forgot the second part of the question.
The second part was likelihood of bladder problems when a hysterectomy is done.
Okay, so that's again a little bit individualized. Depends on the reason for the hysterectomy. If there was already some sort of prolapse present, it can depend on an individual woman's history, birth history, whether or not she's had pregnancies and deliveries in the past, and then just individual kind of changing in pelvic support structures over time. So it's more related to those things than the hysterectomy itself.
Understood. So what I'm hearing is everything is very personalized.
It is. That's why we, need to take the time to kind of chat with each individual patient and understand their history, because all of these other things have an impact on what we're looking for. And that's why when you come in, we want to do your history first before we do the exam and everything else, so we know if we need to be looking for separate issues while we're doing that exam.
Absolutely, that makes sense. I have another question that says, parents can be wary of taking their child to their first appointment because in some people's minds that can mean that their child is thinking about or is being sexually active.
Sure.
So what would you say to those parents to help them understand the importance of beginning those visits early in their kid's life?
I think getting that information out to young girls so that they understand more about their own bodies, they understand more about how their reproductive system works, and they understand things about their sexuality that we can discuss with them, could only possibly be beneficial. A lot of young girls who sometimes come in for these first appointments ask questions like, well, my friends told me this, is that true? Or I saw this on the internet, is that true? So to be able to provide the honest information sets them up to do a little bit better, I think, moving forward. And certainly you do want to be having these conversations about things like contraception or sexually transmitted infections before people are starting to have intercourse, if possible. So that would be kind of the best scenario if these discussions and prevention methods are put in place prior to that starting. So it doesn't mean they're going to do it or they have to do it, but it means that they'll, be educated and equipped to hopefully make some good decisions.
Right. And that's all you can ask for, right? Just
Mm.
the young person to understand what it is they're talking about, what are the, repercussions, how to prepare yourself. So those
Yep.
discussions are so important. Do you have any maybe advice for parents that aren't coming into the office but want to have those conversations at home? How do you start that conversation?
I would say just, try to be as honest as you can. It is certainly an awkward conversation for parents and children. But if you just present it as facts and education to try to move forward, to be as healthy as possible, then I think that's kind of the best thing you can do. And, letting your child know that it's okay to talk about these things. This doesn't have to be completely taboo, so that hopefully if any issues do arise, they're comfortable again to come back and ask questions and find out more information as needed.
Understood. So I have a personal question. I know I was, a health student, and we were always taught to use the clinical terms because parents sometimes feel uncomfortable using the clinical terms. So they make up nicknames or, they
Yep.
just allude to it without saying the words. What's your advice on that?
That is a discussion I think that goes into a lot of other categories besides just obstetrics and gynecology. I think if you can use anatomical terms, then that is probably the easiest way to do things. And it sets a standard, and it doesn't provide a little veil of cutesy or other things that might then change the tone of the conversation. So I think if you can do that, you should, but you know, uh, I think every parent has their own relationship with their kids, so it might differ a little bit individually. But if you can try to use the anatomic terms, at least at a base to start, so there's some understanding, then that's probably good.
Absolutely. I agree. So we have gone through all of our questions that have been sent in. So at this time, I want to ask everybody watching, if you do have any last comments or questions, go ahead, type those in the chat and let us know. But um, I know that yesterday when we spoke, you had mentioned that there's a new guideline
Yeah,
or
it was funny
so
timing.
yes.
Um,
So did you want to give us a little update on those visits?
Yeah, so one of the things that came out yesterday was, so the Women's Preventive Service Institute is an organization that sets up what we should be kind of discussing at, or provides recommendations of what we should be discussing at all of these annual visits when we're checking in with women. And yesterday they added a new thing related to anxiety, so screening all the way from when you're 13 years old throughout the lifetime. To make sure that we're checking in on that, as anxiety is equally as common, sometimes more common than depression, which is something that we do regularly screen for at baseline as a gynecologist, as well as primary care physicians, pediatricians. We're all doing that pretty regularly, but anxiety was a new element added to some of those screening recommendations, in addition to other things unrelated to true, I suppose, physical health, like a blood pressure or diabetes thing that a patient might be thinking about. We also ask questions related to anxiety and depression, as well as things like substance use, domestic violence or abuse situations, sexual abuse history, anything like that. So sometimes I think patients are occasionally caught off guard by having all these questions asked, because a lot of things that go on in a gynecologist's office are certainly personal, and it feels a little bit like prying, but all of those things are hugely impactful on overall wellness, and some things specifically very impactful on gynecologic health itself.
Absolutely. Yeah, we've all had those questions where they ask you, "Are you depressed?" And you're like, "Well, I don't think so."
Yeah.
It intertwines and it's all important.
Yes,
We have two more questions have come in since we started chatting.
sure.
Can an OBGYN help with weight management? Is that something that they can talk about with them, or is that more of a primary care conversation?
It's certainly a discussion that can be presented and started at the gynecologist's office. It's something that we're definitely trying to keep an eye on for all patients, and especially leading into any of those that may be considering pregnancy. Healthier weights at the start of pregnancy will make pregnancy healthier. So we're trying to focus on that in women in their fertility years that might be considering pregnancy. But it's something we can start with. I won't necessarily say that every gynecologist is going to have all the resources, depending upon what amount of involvement and further management is necessary, but it's definitely a place to start. It's a place to start to discuss what a healthy diet really is, what exercise you should be really doing, each day or each week to try to help and benefit. So it's definitely a place to start.
That's good. And I feel like that can be more comfortable because, I mean, your OBGYN probably knows the most about you. So those are those tough conversations that you have. So there's a level of comfort there.
Yes, I think that's probably true.
Yeah, so I think this next question, I'm assuming, is from a student. The question is directed toward you. It says, what was your experience applying to residency programs?
It was kind of fun. You got to travel back then in the past when you weren't all stuck at home. We got to travel around to all the different hospitals for interviews and see how we were doing and what you liked, and you got to experience different things. It's a little hard, I will say, to fully understand what a place is going to be like from a one-day interview. So don't rest everything on that. Try to talk to some other people who maybe who have been in that area and know anything about the program. But you can get a relatively good idea just by usually you're chatting with some of the current residents and do they overall seem happy? How's their morale doing? And whatever else.
Perfect. I think that's great advice. Well, if nobody has any other further questions, we're going to go ahead and wrap up. Dr. Pashugo, thank you so much. Again, this will be sent out. So if you do have follow-up questions, reply to the email that's going to be sent out with this video, and then we can get them on over to you. But thanks so much for your time today. You were filled with great information.
Absolutely. Thank you very much for having me. It was fun.
Of course. Thank you all for watching. We will see you on our next webinar. Bye-bye.
Thanks.